Let us talk on some aspects relating to tocilizumab for COVID-19. In a previous video, I described the cytokine storm and outlined the important characteristics of this in some patients who get COVID-19. This is a list of the some of the cytokines, including cytokines such as IL-1, IL-6, interferon gamma, TNF alpha, etc., which I have described previously. Let us focus on IL-6 as an important cytokine that causes issues in patients with severe COVID and which could be neutralized in the appropriate instance. So if you look at this schematic, you have the IL-6 receptor, which is found on the membrane, or it is soluble, that is, it's free. So the IL-6 chemical will bind to both types of receptors, that on the membrane and that is found free as soluble IL-6 receptor. So what is tocilizumab? I have previously described to you some aspects about monoclonal antibodies and biologics. And the general characteristics of these can be found in that small clip. So tocilizumab is a recombinant humanized monoclonal antibody against both the membrane and soluble IL-6 receptors. That is the receptor that binds to the IL-6. So when the monoclonal antibody binds to the receptor, it inhibits the binding of the IL-6, the chemical called IL-6. And we know the actions of this cytokine called IL-6. So this is a schematic that shows what tocilizumab does. The antibody in red binds to the receptor both on the surface of the cell and that is soluble, and it prevents IL-6 binding. So thus, the inflammatory signals will be blocked, and that is an important anti-inflammatory agent which has been approved for use in certain rheumatological conditions, including rheumatoid arthritis and a condition called giant cell arthritis. And clinicians are well aware of this drug, and we have been using that in clinic. So when it comes to COVID-19, early observation from China showed that it improved the outcomes in hospitalized COVID-19 patients. This was followed by large observational studies in critically ill COVID-19 patients, and a mortality, that is, mortality benefit was demonstrated, that is, a reduction in death. However, subsequent randomized clinical trials produced conflicting results. And this could have been because of the difference in size, design, and illness severity of the participants included. Some failed to show a mortality benefit, that is, reducing death. However, the studies had fewer than 300 patients in each arm, therefore it was underpowered. Critically ill patients were excluded, and that is the main group that we are targeting in certain instances, and there were imbalance in the use of steroids. And we know that dexamethasone is an important drug in this group of patients who have developed very severe COVID. This was one of the studies that were published that included patients with moderate disease, and they did not find much benefit. However, there were two important studies that came after that. That is the REMAP-CAP study. That's a long, it's a mnemonic for a long name of study for community-acquired pneumonia. 803 patients were included, and it showed a survival benefit, that it's reduced death. This study was limited to critically ill patients, and following this study, we were still uncertain whether it would be beneficial in hospitalized, non-critically ill COVID-19 patients. Next came the recovery trial, which is an important landmark trial in COVID-19. It is a multi-center, randomized, controlled, open-label platform trial that examined the role of several treatments in hospitalized COVID-19 patients in the UK. 177 sites recruited patients, and more than 27,000 hospitalized adults with COVID-19 were included in this trial. So it was a very landmark trial. Ran in the tocilizumab arm, the patients were randomly assigned to tocilizumab or usual care, and the groups were selected as having hypoxia. These were the groups that were selected for the study, those with hypoxia, that is oxygen saturation of less than 92%, systemic inflammation as evidenced by CRP greater than 75, and there was no clear evidence of active infection other than the SARS-CoV-2 viral infection. 4,116 adults were included, with the numbers distributed between tocilizumab and usual care as shown in the slide. The mean age was over 60 years, and it was predominantly white males. Median time from hospitalization was about 2 days, and 14% were receiving invasive mechanical ventilation at the time they were randomized. 82% of patients in both groups were receiving corticosteroids, and this was in contrast to earlier studies because by that time, the benefit of dexamethasone had been proven, and these patients were having this drug. The primary outcome was all-cause mortality, that's death within 28 days, and that was lower in the tocilizumab group as opposed to usual care. And those receiving tocilizumab were more likely to be discharged from hospital within 28 days as opposed to the other group. So that was an important finding in this group of patients. So what it said was that compared to usual care, tocilizumab reduced death span absolute difference of 4% among patients with COVID-19 who required oxygen and had evidence of inflammation. Those were two important points to be noted from this slide. This was the trial that was published, and it was an important step going forward. There were limitations in the study. It was an open label study. Non-fatal infection, other adverse effects were not collected, but we know that there were no deaths from secondary infections. Some physiological data were not collected, such as hypoxemia as a longitudinal measurement. Some missing data was there, and long-term mortality benefit is still unknown. We know the 28-day mortality or benefit was there. It reduced death, and we are waiting for the pre-pan analysis in 6 months' time. So these were some of the limitations of this study. So the conclusions from the recovered trial was, is there a place to include tocilizumab for severely ill COVID-19 patients? Yes. Still, there are questions that remain in patients with CRP less than 75, pediatric patients, there's a study going on at the moment, and in gender and racially diverse group, because we know the study included white males predominantly. We have to remember that the 28-day mortality is still 31%. It's still unacceptably high. And because of this, additional therapies are urgently needed, including other immunomodulators and spike protein antibody. And these studies are ongoing at the present moment. So it's an important advance, but we do need other advances coming on. So who should we give tocilizumab, or who should we consider tocilizumab for? So the NIH has come up with guidelines, and these are important to be followed specifically. And these are the guidelines that the recommendations given. So the dose is 8 milligrams per kilogram body weight, that's actual body weight, up to 800 milligrams in combination with dexamethasone. That's a very important thing to remember. In combination with dexamethasone, they should be receiving dexamethasone. And there are some condition that we have to be careful in giving this drug, and that has been given at the bottom of this slide, including significant immunosuppression, particularly those with a history of recent use of other biologics. Platelet count less than 50, we have to be careful and we may hold it back. If the absolute neutrophil count is less than 500, and the other cautions are listed in this slide. NICE has also come in and given some recommendations, and this is a very important set of criteria to follow, because they should be having or completing a course of steroids. They have not had another IL-6 inhibitor just before the treatment option was considered, and there is no evidence of another bacterial or viral infection, and that they have either that they need supplemental oxygen or C-reactive protein is greater than 75, or are within 48 hours of starting high flow nasal oxygen. These are important criteria to be followed as per NICE in the UK and the NIH in the US. The recommended dosage for tocilizumab is a single dose, 8 mg per kilogram by intravenous infusion. The total dose should not exceed 800 milligrams. So in summary, we know that SARS-CoV-2 causes immune cell activation, and one of the important chemicals released is IL-6, the cytokine called IL-6. IL-6 binds to either the membrane receptor or soluble receptors and causes inflammation or hyperinflammation if the levels are very high. Tocilizumab is a monoclonal antibody against the IL-6 receptor, both on the membrane and that is soluble. So when it binds to the IL-6 receptor, the IL-6 cannot bind to it, and therefore the hyperinflammation is reduced. And this has an important place together with dexamethasone in the appropriate clinical categories, and we must meet the clinical categories before considering this drug, and the guidelines should be followed. Thank you very much.